Started, sir. Good evening. Thanks to each and every one of you for being here with us today. I, Ankit Dogra, along with my teammate, Mr. Amit Saxena from Medical Services, Jagsonpal Pharmaceuticals Ltd, are very pleased to welcome you all to the Q&A session on OMICRON, the new emerging threat organized by Delhi Medical Association, Vaccine India, and Mera Swaasth Physicians Network, which digital partner Jagsonpal Pharmaceuticals Ltd, makers of LycoRed, the cell protector, lycopene softgel capsules, Doxypal DRL capsules containing doxycycline, and Jepitone syrup of iron, zinc, and vitamin B complex to promote well-being and restore vitality. Dear attendees, if you have any suggestions, questions, or clarifications, please post in the Q&A box. Please note this webinar is streaming live on the Facebook. The link is shared in the chat box. Also note, for the future reference, we'll upload this webinar on our YouTube channel, Jagsonpal Medical Insights. Now, let us welcome the moderator of the program, Dr. G.S. Grewal, President, Delhi Medical Association, to kindly initiate the program. Over to you, sir.
Good afternoon to all of you. It's a great pleasure for Delhi Medical Association, Vaccine India, and Mera Swaasth Physician Network to host this very important session on OMICRON and the questions therein. It is a matter of honor for us that we have the National President, our dear Dr. Shahjanand Maharaj from Patna, who is joining from the Operation Theatre. Thank you very much, President Sir, to have joined from the theatre. It shows your dedication to all of us and to the country. We are also privileged to have amongst us the Honorary Secretary General of Indian Medical Association, Dr. Lele, who has been pioneering the entire process right from day one and has helped the entire nation and all the branches and all the presidents and secretaries in this time of difficulty. It is a privilege for me and my co-host, Dr. Ajay Gambhir, the Honorary State Secretary, to have amongst us the distinguished scientist from India, Dr. Gangakhadkar. I'm sure you all remember him on the national television facing the barrage of questions from the press, and with his very nice little sardonic smile, always taking the whole problem and solving it more with his smile rather than his answer. Thank you very much for being with us, Dr. Gangakhadkar. It's a pleasure. Ladies and gentlemen, it is a pleasure that I invite our National President, Dr. Shahjanand ji, to please give his opening remarks.
Thank you very much, sir. Thank you very much for calling me here. So, respected R. Gangakhadkar, President, Delhi Medical Association, Dr. Grewal is a very good friend of mine and is very helpful for us, and Dr. Ajay Gambhir. Very good subject we have chosen, sir. And we are taking always advice with this ICMR people, and we are follow the ICMR direction for this corona period. Sir, very good subject, question answer. So I am in operation theater, so uh, so I am only joining and excuse me, sir. So I am taking a leave from this meeting, sir. Okay, thank you very much, sir.
Thank you, sir.
Thank
It is a pleasure and honor for us, for you to bless us, even from the operation theater. So kind of you.
Thank you, boss. Thank you, sir. Thank you.
I now invite our Honorary Secretary General, Dr. Jayesh Lele, to please give us the direction and blessing to the entire audience.
Yeah, thank you, Dr. Grewal, sir. Respected President, Delhi Medical Association, Dr. Grewal, Dr. Gambhir, our Secretary of the Delhi Medical Association, and of course, a well-known faculty, Dr. Gangakhadkar, with whom I have shared many times on the TV as well as on some platform on the discussion. Well-known, in fact, in Maharashtra also, he has guided us to form the task force with the Dr. Mangesh Patel. And today's very important topic has been taken up, especially the question answers, the queries people will have, so many things. Suddenly cases have risen in last 1.5 months. But we need to understand that there are 2-3 things we must understand, that whether this such kind of change of the variant will keep on occurring and how long it will occur. It is good that this variant is on a milder issue, wherein the death rate has not increased to great extent. But of course, the Delta was very powerful, and in the second wave, we had a lot of tough time. But still now in India, we are having such kind of activity, and the patients are rising at some places. Now in Maharashtra, I find that the patients have gone down, but the south side patients have increased. And so those questions will definitely help us to inform our patients, tell the patients, and guide us, our fraternity also, very important thing. So it's a really good to have our senior respected faculty and Delhi Medical Association. I congratulate to arrange such program, and I'm very happy that this is being streamed live and it will be available afterwards also to the doctors who have missed out to afternoon to see the session. So thank you very much for inviting me here. All the best from the IMA headquarters. And I'm sure it's going to be a very interesting, very fruitful, very important session to all the faculties. Thank you. Over to you, sir.
Thank you, Dr. Lele. Thank you. You're always a pleasure, always smiling. And the entire marina, the Bombay beach, remembers your smile every time we reach there. We say Dr. Lele is coming from the ocean. So you're always from the ocean. I now invite our Honorary State Secretary, Dr. Ajay Gambhir, to kindly introduce our expert who is going to answer your questions and queries. He is well known to the country, to the world, but as a mark of respect towards our expert, I'll invite Dr. Gambhir to kindly introduce Dr. Gangakhadkar.
Thank you, Dr. Grewal, known as Bobby. So I'll give you a short introduction at a large. He's a pediatrician at PAR from Aurangabad and specialized in the MPS. So knows the clinical part and also the public health part. And that's why he has been very successful epidemiologist. And now he has been a part of Indian ICMR and a communicable diseases as a in charge, and got a GC Pandit national chair at the ICMR. He has been the pioneer and a part of strengthening the HIV/AIDS program and has been the director of the NTAGI. So all those research you are looking at, the lab, the genotyping lab is started from Pune. So he made Pune as the headquarter, and later on, as all the good people either from Bihar or Maharashtra, they have to come to Delhi. So government of India wanted his service. We say export quality of every state comes to Delhi and we get the best. And he was here as a ICMR director, and most of the bureaucrats used to keep him on the right side so as to get the right information. Now, the last important thing is he has been recently inducted into a latest group. We had the SAGE meeting, the strategy advisor group on immunization, but he has been put into SAGO, that the strategy advisory group of origin of disease. This is a new committee WHO has made. Now they are going on Indian philosophy that why the new origins comes, why the new viruses are coming and why the new diseases are coming. And no one knew the answer, and they will kill pneumococcal and the other strain will come, they'll kill one COVID. So you need a very innovative and thinking person. And with these comments, and that's why we want to listen to him again and again, and we'll listen to him again and again. Maybe every week we are doing that. So with this small introduction, I'll invite Dr. Gangakhadkar to say on the present situation of the COVID and way forward, and then we'll take question answer. Dr. Bobby will do that.
Thank you, sir. I didn't know I was to make a formal presentation, but I would try my best giving extempore kind of thing, or I can show one which I had used very recently.
Yeah.
Do you want me to use the presentation?
Yeah.
I would request you to kindly give a little few brief on the present prevailing situation. Then I have a list of around 35 questions, which I put in certain brackets. I won't put 35 questions to you. I put them in certain brackets, and we will put those brackets to you. But introductory lines you may please give to the audience on two things. On two things, sir, because we are already moving ahead. On two things, our expert, we want you to listen to you. One, there is a very strong word going around, Omicron to bahut mild hai. Omicron to bahut mild hai. Now, what are the dangers of calling Omicron mild? That is my first question. Number two, in high-risk categories, when we are not able to find out Delta or Omicron, do we, like we did during the second wave, the day the person used to come for fever, we used to start getting inflammatory markers blood test done. We used to get CT just done on the third day. So do we follow that routine at the moment, or is it different? So if you can answer these two, then we will follow it. Thank you, sir.
Sir, what I will do is, since he asked to present something, I know this is at least 3 or 4 days older presentation. But I would start off with the quick presentation.
Fine, sir. Fine, sir. Please be comfortable.
I will use that so that it starts as a backgrounder, and then we can move ahead with whatever questions come. This is only about 10 minutes presentation. In November 24, 2021, it was more of, oh my God syndrome. None of us ever expected that there could be a new variant which would have 50 odd mutations that were added to Wuhan virus from South Africa. 37 of these mutations tend to lie in spike protein. 14 of these mutations have never been observed before in any of the variants so far. Of the 37 mutations, what was more difficult to understand was 15 are in receptor binding domain, which have implications in terms of the binding affinity, how quickly the virus can enter inside. And if you actually look at, people wondered, why did we miss this virus after Delta? Because suddenly it has accumulated 50 odd mutations totally. Then they look at the rate of mutations that one would have required to generate this Omicron variant. This rate of mutation is 2 times faster than what has been seen among other variants. So, which essentially means this is something. The origin of this particular Omicron is going to remain as an enigma. Now, one of the issues that we have to remember, you look at the phylogenetic tree here. If you actually see the phylogenetic tree on the left, you will find that the red line represents Omicron and rest of the variants are noted at the bottom there. You find there is a big gap between Omicron and other variants. What does it essentially mean? Does it necessarily mean that Omicron is far different? It is different than other variants, even if you look at antigenic cartography. Now, antigenic cartography is like mapping different antigens and placing them at a place and try and see how far they have evolved. You find Omicron, compare that with other variants that have come so far. You find here also it is placed far away from other variants that we have known. So essentially, it's going to bring out one question in everybody's mind: is this only antigenic drift, which has reached all that far before it moves into antigenic shift? The question cannot be answered so easily at this juncture. One of the scares that we had when we heard about Omicron was, does it have, how does it impact the propensity to spread, its transmission efficiency? Does it cause more hospitalizations and death? And does it evade vaccine-induced immunity? Now, the findings that came about, they suggested, if we were to summarize very quickly, is this particular variant has a high binding affinity because of the mutations that have taken place in RBD. It tightly binds to the ACE2 receptor. This does not like to go through the lungs for one simple reason: it has 10 times lesser ability to move through the lungs into the body of human being, which essentially is one of the reasons why we don't see so much of dyspnea or lung pathology in Omicron per se. And what is also important for us to look at, what are the kind of symptoms that we have so far. The symptoms that we have noted are far too milder. You look at sore throat, fever, cough and diarrhea, and fatigue as some of the symptoms which are more likely to be observed in Omicron compared to what you would see in Delta. And you look at the classical symptoms of Delta, which are not being seen with Omicron. They are loss of smell and taste, then red irritated eyes, sneezing, runny nose, and shortness of breath. And therefore, what it actually indicated was the symptoms tend to be pretty mild. And then we may have to diagnose this particular variant and try to decide on the treatment across. Now, if you look at the number of reported symptoms that tend to occur, they did not differ between Delta and Omicron. It was almost all of them had at least a median of 4 different symptoms that could be seen among the cases that have Omicron or Delta per se. Now, we tend to hear a lot about its ability to evade vaccine-induced antibody responses. Now, if you look at vaccine effectiveness against hospitalization due to Omicron, there's one thing which we suddenly start realizing: the immunity that it tends to wane even if you have 2 dosages of vaccine. The longer you take before you get exposed to Omicron, perhaps you will find that the ability of these vaccines to reduce the risk of hospitalization, it tends to drop down. Whereas if you provide a third dose, perhaps things can be little better off. Now, what is more important for us to understand? So it also tells us that in India, when we started off providing 2 dosages of vaccine, we started pretty late compared to England, or our coverage was comparatively lower at that juncture, which essentially means we may see increase even in hospitalizations over a period of time as Omicron wave progresses, because you will find it will start affecting those who have received the vaccines 2 dosages far too earlier, and therefore that becomes an important issue to keep at the back of mind. Now, one question that will come to everybody's mind: is this due to the vaccines that we provide, that it really has a milder symptoms, it doesn't lead to hospitalization so easily, or is it due to the virus itself? Now, if you actually look at the data that has emerged, we look at the vaccine efficacy data, and it tended to show us that the protection tends to fall off if the second dose has been received far too earlier, and then the exposure to Omicron actually occurred. But if you actually look at the data that comes from US, where they compared children who under 5 who had not received the vaccine, obviously. Now, these were divided into 2 cohorts, Omicron and Delta cohort. And if you look at this particular data, you suddenly realize that when it comes to hospitalizations, ICU, and mechanical ventilations, there was almost 70% reduction if you look at these outcomes as important event, if you compare Omicron with Delta, which essentially means there is the severity is also affected because of the virus itself. Severity becomes lesser because of viral factors in Omicron. That's another issue that we should keep at the back of mind. What is most important? We tend to get worried a lot because of daily new infections that you are seeing in huge numbers. One must always remember that these numbers are going to be pretty high than one would like to see or read at any point in time. But what is also important for us to understand that we are now into the third year of this pandemic. Now at this juncture, we are not looking at stopping the spread of infection, but what we are looking at is risk mitigation phase. So what should we be doing? We should not be counting daily new infections because that's something which we should do when you have an unimmunized and naive population, and naive as unexposed per se, in the group where you are looking at. But now it should be daily COVID hospitalizations that occur and deaths that tend to occur because of COVID. They need to be monitored well. Moreover, one must remember, some people ask question, what would be the number of new infections that might occur? The simple answer that I can give is it's going to exceed hugely from the peaks that we have seen in the second wave. And would that be ever reflected in the numbers that we might see? Perhaps we don't know. That number cannot be drawn so easily, no matter how hard different modelers are trying to project. To my mind, the number of assumptions that we have do not allow us to come to any figure that we can think about. And why am I saying that? That is because one has to remember the people are coming with mild symptoms. When they come up with mild symptoms, it is something which will depend on the health-seeking behavior of people, whether they would like to go to a doctor and get their RT-PCR done, even if they have a mild symptom. We know our population, we may perhaps avoid doing that, taking a cue that I will wait for 1 or 2 days. If the symptoms persist, then I will go for it. And we must also remember that the symptoms are going to remain as milder in all probabilities. There is a fear of dying or temporarily living alone in a hospital, and that has been associated with Delta and even in the first wave so much that people would perhaps even refuse to. They may not like to go ahead and get RT-PCR done, mainly because there could be a fear that I may be separated from my family just because I have been found as positive. There are campaigns which suggest to them that this is a less scary, common cold-like infection. People will ask questions to themselves. If that is the case, do I go to a doctor every time when I get common cold? So why should I go and show him and get RT-PCR done? That's another issue that becomes important. Availability of home testing kits, it has increased dramatically. And when they go for home testing, they may not report that they are infected because they have different fears that we discussed earlier. And naturally, all this is going to impact on the numbers. So it's very difficult to even think what would be the number that may be occurring as of now, because people may not, this entire sample cannot remain as a representative sample to decide as to what could be even the estimated number, given the different variables that we have. What is also important is people at this juncture are trying to weigh the competing risks and benefits. As far as the information that has gone, it tends to say that health risks continue to be smaller. And then they look at another factor that is livelihood related, that I'm likely to lose my wages if I don't go for work. And depending on their own personal situations, they may choose to go, they may choose to neglect health and then decide to go for work even if they are infected. Now, one of the things which we have to remember, when on 29th of November, this is a very interesting graph that comes from GSET data that is submitted to WHO, the genome sequencing data. 5 days after the first report from South Africa, if you compare what kind of strains had we submitted to GSET, you look at South Africa. South Africa had almost 86% of the strains that were coming from OMICRON. But if you look at India, we had 94%. You look at UK, USA, they were almost close to 100% were having Delta infection at that juncture. But if you look at India, you see a red bar in India, which is a far smaller fraction, but the report that perhaps they were having Omicron even at that particular stage become really important for us to recognize. And now we have seen an explosive replacement all over. Now, this is a data that has come from GSAID, the data that all INTACOG also submits on Jan 10. And there you suddenly find 82% of the people are currently having Omicron infection as per the samples that have been submitted. Now, does this mean that perhaps these are representative samples? They may not be. Because essentially INTACOG was focusing initially on international travelers, and therefore the sample is contaminated. So we really do not know what it is. But if you actually look at what exactly may be happening at this point in time, you perhaps can infer better by looking at the indirect data on hospitalization and deaths that are occurring. Compare the same, no, excepting for death. No, you can compare hospitalization related data with the number of infections, and you realize you are perhaps facing a milder infection. So Omicron is almost replacing or has probably replaced Delta to a very large degree in India. Now, what is also important is, if you want to look at the morbidity from Omicron and Delta in India, one of the things which becomes very important for us to understand is the SGN dropout strategy in India was very difficult to enforce. Firstly, we didn't have so many kits to actually do SGN dropouts when the infection was reported. So we had to do genomic sequencing. And when you think in terms of genomic sequencing, we must remember it takes about 3 days time to process these samples. What is important is each of the sample requires about 10,000 rupees as a cost to process them. And naturally, the turnaround time is likely to be different in different INTACOG centers. So the data that comes to you, when you look at different states that are saying, I have so many Omicron cases in last week, we do not know, they were tested last week. But when they were collected is an issue which remains as a question mark. So the turnaround time and the representativeness of these samples make it very difficult to comment whether you have a solid evidence to say Omicron has replaced Delta or has not replaced Delta. And self-testing has picked up so dramatically in urban areas that we will never have a representativeness that would come so easily for interpretation. Now, if you actually look at where we are, you will suddenly find that we have covered our people with 2-dose vaccine significantly. It's more than 71% at this point in time. And if you look at the new cases that are occurring, if you compare them with South Africa is on a huge decline. But you compare that with India, now you find that we have just started an upsurge. And if you look at the new deaths that are occurring, they continue to remain at a lower level, which essentially means if the pattern will be produced, perhaps it's unlikely to be far different than what you would see with South African pattern that has been reported. Right? Now comes the more difficult tasks for all of us to interpret. Now, so far, when it comes to Omicron, this is also a mutating virus. We know it has a very high transmission efficiency. And if you have high transmission efficiency, we must keep one thing at the back of mind. The more number of bodies in which the virus is going to replicate, you will find, since it has error-prone enzymes, it is likely to lead to changes, mutations that tend to occur will become far more commoner even within Omicron. And within a month's time of report of Omicron, we are now talking of 3 different lineages. One is called as BA1, BA2, and the third is BA3. So far, BA3 has not been reported in India. You have BA1 and BA2. Now, why do they become important? The gene dropout that we talked about, it tends to occur because of gene deletion that tends to occur in spike protein at the point mutation where 69/70 there you have a deletion that occurs, and therefore S gene is not picked up in RT-PCR if you have that kind of a RT-PCR test that is available. But this is a feature of BA1. But when it comes to BA2, BA2 does not have S gene dropout, which essentially means it doesn't have the deletion at 69, 70. And that's going to affect our ability to interpret whether the person has Omicron based on S gene dropout. And that's something which we have to keep at the back of mind. BA2 is largely unknown in terms of, does it increase transmission efficiency? How is the disease severity in BA2, which is a newly emerging variant as such within that particular lineage? And there you find that if you try and look at India, do we have BA2? Yes, we are also showing an increase in BA2. If you look at the blue colored box that you see right at the end of the bar chart, no, there you are saying that India continues to now have reports of BA2 that tends to occur, which essentially means testing dropout strategy, to test is not going to work over a long period of time. It will essentially depend on what is the impact of BA2. If I am to compare BA2 with BA1, is BA2 more fitter for transmission? You will find BA2 will also start replacing BA1. So we cannot, at this juncture, we have to just wait and see. But the only answer that I can provide is any screening strategy as of now with respect to S gene dropout is likely to be flawed over a period of time. We may have to watch. Now, the key question that comes to everyone's mind, if you have vaccine coverage very high, and then I have large proportion of population which would be affected by Omicron because it's a highly transmissible variant, and it will also induce antibodies. And there are multiple publications which tend to tell you that if you get Omicron, you may be protected against even Delta infection, even if you had not acquired it before. Does this mean that this is exit of COVID? We still do not know that. And why am I saying that? That I'm saying only because we don't know whether Omicron is a new Tom and Jerry kind of a cartoon. Why am I saying that? As I said earlier, we do not know how Omicron has come up suddenly, because earlier Delta variant had far lesser number of mutations, and then suddenly you face a Omicron as a variant where more than 50 mutations tend to exist. There are multiple theories. One theory tends to say that the mutations continue to occur in a village where people were not moving from that village to elsewhere, and they provided fodder for the virus to mutate. It's fairly unlikely in today's era. The second one tends to talk about HIV-infected individuals cohort, which was followed by Abdul Karim's, Salim Karim's group. Now, there, what he did was when they looked at that particular data, he found that HIV-infected individuals, the infection persisted for a long period of time in their bodies, and they kept on doing the genomic sequencing until day 200, not knowing fully well whether what they are observing is a manifestation that this is a chronically evolving kind of a mutant inside, because it was done on a retrospective basis. But what they found was actually a large number of mutations that occurred even in that HIV-infected individual's body was within those 200 days were also related to one or the other variants, including Omicron per se. So what they did was they started thinking, could there be any other way? The scientists came up with one more suggestion, that perhaps all of us know that the list of different animals which can harbor these variants or actually get infected with SARS-CoV-2 is increasingly adding new numbers of these animals. Now, if that is the case, is it possible that this particular virus from human beings went to animals, and from animals it came back again to human beings, and then it went on as if it was a match of table tennis, and what we are seeing now is a final product? So they tried to compare pre-outbreak Omicron mutations, and they found among all the so-called known animal reservoirs that they have tested, they found this particular pre-outbreak Omicron mutation was closest to mouse, a rodent population which is fairly common. And then they tried to look at the post-outbreak Omicron mutation. Perhaps what comes more closer is it could be from a mouse, or it could also be from a cat that may be there. So essentially, we are seeing a newer question that tends to come into our own mind. And the next question that comes, people would get worried whether there could be a newer variant that will come, or the SARS-CoV-2's exit strategy is the final Omicron wave that we are seeing today. If you actually believe that this animal and human interactions are likely to bring in more variants, then perhaps the only answer that might come is, we have to think whether it will stop only when you might immunize even the animals, and that is something which we have to really think about in near future at this juncture. But there is still a hope that new medicines are coming, and if new medicines tend to come, perhaps this issue may become less important if we have more effective medications that become available in near future, and the pandemic then with a new or newer variant doesn't pose any kind of a problem. So essentially, what does it mean? You might see all kinds of debates that might occur across. People belonging to one camp will fight with another camp and try to speak animatedly about their own views, what might eventually happen. But we need to have a patience. We need to wait for some time to actually know what could be the future of the pandemic. Thank you.
Thank you, Dr. Gangakhadkar, for such a nice illustration, and also telling us that zoonotic disease, our linkage with the animal world, we should not forget. And God doesn't want us to forget. Now we have a lot of questions coming. 5 are already there, 30 is already there. So over to Bobby, Dr. Grewal.
Thank you, Dr. Gambhir. Thank you, Dr. Gangakhadkar. This is when you have a scientist, then you get a panoramic view of the issue. I'm sure all the attendees, you must enjoy. Okay, you go to a chef and ask him कि दाल कैसे बनाई, he will tell you दाल चीनी कहाँ से खरीदी थी. So that's what you have when you have an expert, a scientist. You get everything panoramic. Well, Dr. Gangakhadkar, we'll start with the questions that people have put onto the box first.
Yeah.
Omicron being a mild infection like a common cold, can it be taken lightly as quarantine is mandatory for not only for avoiding transmission, but also for medical legal purpose, especially for professionals? Laxity, there is no. So what he's trying to say is that taken lightly, one side people are saying lightly, but there is a strong legal binding for you to be in quarantine. So what is your statement on that, sir?
Sir, I still strongly believe, however difficult it must be to prevent transmission that could occur because of this variant, or somebody acquiring this infection from any person whom you may not know. It is important for us to remember, however mild the infection may be, however the chances of hospitalizations may be low in people who have received 2 dosages of vaccine as of now. But the reality of life is, what we do not know is about the post-COVID impact. No, we know as of now that people who have mild infection or asymptomatic infection, they also are now part of the post-COVID syndrome. And one has to remember that COVID is a multisystemic disease that we learned at the time of Delta or even in the first wave. So it tends to affect all organs. And when it affects all the organs, we do not know, since it's only 2 years since the start of the pandemic, we do not know what are the long-term effects on different organs. So far, what we understand is perhaps it may unmask diabetes. We have people who tend to become obese after COVID. We know that some of them, they tend to have some neurocognitive defects at this juncture, because it is also known that this particular virus has a propensity to affect the brain per se, the glial cells at this juncture. So essentially, one good thing that we must remember is, even if it is mild, even if it doesn't lead to hospitalization or deaths among vaccinated, what is most important is not getting infected perhaps reduces the risk of unknown much better, rather than what is known about mild infection and others. And if we manage to come out of it easily, because if this is a rapidly spreading infection, you might have only about 6 to 8 weeks time, and the infection will try to spread across and infect as many as possible. But if I manage to not to get infection for 8 weeks time, I'm also reducing the risk of unnecessarily taking a chance whether I would have a long-term effect of COVID, which nobody knows as of now.
Dr. Gangakhadkar, before I proceed, a very basic question. What is the difference between quarantine and isolation?
You have asked me a little difficult question, because I know I used to fight in the earlier times when in the first 6 months, the terms, the way we are using are incorrect. It should actually be exactly opposite when it comes to when we say quarantine and isolation. But that has happened right in the beginning when the pandemic started, and people learned about those terms, and then there was a bigger choice whether we should call, again, reverse the whole thing, and say what is quarantine and what is isolation should be truly spelled out, because it was felt that it may create more confusion in people's mind. So these terms continue to persist, but I'm sorry, we know there is a mistake.
So anyway, so I think for the general people, what is important is if you're hospitalized, one, but if you're at home, then within the premises of your house, if you are alone positive and the others are negative, please stay away from them. And if more than one person is positive at home, you can be together in one room. And law permits you that after 7 days today, you can come out of your house outside into the world. So let's not get into difficulties. It is 7 days, Doctor, for Omicron today. So let's settle at 7 days. Yeah. Okay. Now the questions which are coming is, when it is not possible to differentiate between Delta and Omicron clinically, is it possible?
Clinically, yes, sir. There are certain distinguishing things, in terms of symptoms. Let's look at symptoms. There is no loss of taste or no loss of smell. You do not find the person has dyspnea, which tends to come as a symptom. The fever is not high grade as you saw in Delta. Perhaps it tends to range between 100 to 101 degrees. If you look at the exposure, if you could identify exposure, the incubation period continues to be shorter. And what is important is the symptoms continue to be milder, not only in nature, even with symptomatic management, they tend to improve. Important issue is, can I diagnose it with certainty? As I said, it's very difficult to comment as of now on using diagnostic tests. You may be able to pick up Omicron using HomeSure test per se, which is launched by Tata. But at the same time, one must also remember that negative test, that it is not Omicron, doesn't rule out Omicron.
So I think what is important, sir, what is important, because genome sequencing may not happen, but the expert is very clearly telling all of you that clinically you should be able to differentiate that this is Omicron or Delta. It is important for a physician to identify right in the beginning. Clinically, it is possible and it is scientific to separate the two. So the next question, which is amongst all of them, which is very common, again, is that in case what is the importance of CT value in terms when a test report comes to you?
Their CT value used to be considered as important in the first wave. Now, when new variants come, they are going to add to viral fitness. So the moment you say viral fitness, the virus should be able to replicate faster and much better when a new variant comes. So if you actually even reflect, when it came to Delta wave, we used to say the CT value is so less. I need to worry. People used to talk about 17, 20 or 15 as the CT value at that juncture. Now, as the newer variant comes, let's say Omicron, it could become worse. That is because it is the fitter virus which is coming in, which is able to replicate more. So do we assign similar importance to CT value as we used to do it in the first wave? No. So CT value has lost the significance that we used to have in this Omicron wave.
I think the matter is sorted out. Two important messages. Clinically, you should be able to differentiate between Omicron and Delta. If you get an RT-PCR test, the value of CT, which was so high in the second wave, has lost its importance now. Third, you've come to know that isolation at home is 7 days for Omicron. I think that is enough for the clinical part. Now we will come to the treatment part, which is very important these days. What is your opinion about molnupiravir for use in the Omicron infection, sir?
Sir, molnupiravir was a promising molecule. Eventually, it may still become a promising molecule, but it has very low efficacy. The efficacy came out to about 30% in terms of reducing hospitalization. Now, which essentially means when it is 30% efficacy, if I start using it in my routine practice and give those oral tablets to patients, you will find the effectiveness will come down further. Instead of 30% patients improving, you might find that the same tablets, when there is no clinical trial, when people use, it may come out to about 15 to 20%. We don't know. It all depends on patient characteristics. But if it drops down, one needs to ask a question to oneself. Should I be using them indiscriminately? Perhaps not. I should not remain indiscriminate in my usage. And then one might ask, why should I not use it indiscriminately? One must remember that this drug is genotoxic. Now, when we say genotoxic, it has a different implication. What we have to remember is the earlier animal studies had showed that it has genotoxicity as a matter of abundant precaution. Even when US FDA approved this particular drug, they have flagged off this issue of genotoxicity. And the advice that is given is, if you have received molnupiravir, for next 3 months, you should not conceive, at least as a matter of abundant
Sir,
precaution.
I'll simplify it. Sorry to interrupt you. I'll simplify.
Yes, sir.
We talk about the high, because in the younger age group, we are seeing lesser complications. So if somebody is in the high risk beyond 65 years, who's not going to, hopefully not going to produce a child, but would you say that a beyond 65-year-old person having diabetes and high blood pressure, it would be more useful to try molnupiravir on such a person because his complications from the infection can be more than the side effects? Is that okay?
Absolutely. If you actually look at molnupiravir, there were 2 different trials. One was among patients who had standard risk, and one where it was done in high risk. So for high risk, it may be safer to take the challenge, but we need to recognize that the benefits are likely to be low, but at least you have something by way of which you may be able to protect that individual from getting hospitalized, since it's a high risk case. So among them, we may use it.
So I think that another matter sorted out. Molnupiravir is useful in high risk patients beyond 65 years. It is more safer to be used. And in the younger age group, which is a reproductive age group, the disease itself is milder. So therefore, the risk of the disease is lesser. So I think that is also sorted out. Before
Sir,
I continue, yes,
sir,
sir.
if I can add one thing, I think that will make a huge difference if we decide to say no to providing molnupiravir to high-risk exposed individuals within a family. There is a different irrational practice that is emerging, that people tend to provide it to all those who are exposed, saying that this is a rapidly transmitting variant, so they are going to get it. Why not today? No, that should not be done, sir.
Very good.
I think
Very
if
good.
it comes from
So
you,
one
it will be
one
good.
red flag from the scientist: please don't start indiscriminate use. The efficiency is going to go down. So what you're going to be using, trying to save yourself, will not be effective. So be careful. It is to be used in a lot of discretion. That is important red flag from the Dr. Gangakhadkar. So the one I forgot before we came to the investigation, after CT value, when you suspect a case and investigation is done, in the second wave, we were depending a lot on a rising titer of CRP. I can see your smile coming back. The CRP and D-dimer, every 6 hours, people were getting it done. What? And it was considered to be safe limit to get CRP done 4 times a day. So how much is the emphasis on CRP and D-dimer values in this?
Sir, it would not be advisable to unnecessarily investigate. And I
Right.
would also add, not only related to D-dimer and other investigations that we were also doing, perhaps even we can avoid doing CT scans. That was a worse kind of a situation. Knowing now at least fully well that respiratory affection is far lesser, I mean the lungs affection is far lesser in Omicron, we should not only avoid unnecessary blood tests because this is a milder infection, but also ensure that CT scans are unnecessarily
Unnecessary. So I think the emphasis on CRP and CT scans is lesser, and unnecessary investigation should not be done. Now, sir, coming to one more part of the treatment, which is today also the newspapers have come out, is the monoclonal antibodies. Just very few lines, because personally I don't advocate it at all. I'm sure you as a scientist, a red flag to be used, if at all, when. That's all, sir.
Sir, monoclonal antibodies, there's only one monoclonal antibody produced by Roche, which is available in India. If you actually look at these monoclonal antibodies which have been tested against Omicron, none of the monoclonal antibodies among all 7 that are available elsewhere in the world, they found were useful except sotrivimab. Unfortunately, even sotrivimab is not available. Now, why should you worry about these use of monoclonal antibody? We must remember that, if you provide vaccine, developing escape mutants against vaccine is a very, very challenging task. Now, you look back at the history, medical history, vaccines don't lose their efficacy over a period of time, even if the viruses continue to mutate. Compare that with those organisms where we provide medicinal intervention, monoclonals as an intervention. You find that drug pressure and immune pressure adds heavily for the virus as a challenge. It adds a challenge to the virus to mutate and overcome them. We have seen very quickly in last only 1 year's time that monoclonals have become ineffective against even this Omicron, which has come up as a new variant. If we unnecessarily use or irrational use of monoclonals will occur, you will push the virus to mutate further. Since sotrivimab is not available, if I don't know whether somebody has Delta, there is no point in going for monoclonals unless you have definitive evidence that it was Delta.
Full stop. I think please do not get confused. Now, sir, one more question about treatment. Fabiflu and Remdesivir, where do they stand today?
Sir, Remdesivir only among high-risk individuals, 3 dosages is for, only given 1 injection for every day for 3 days is considered as efficient. Favipiravir, absolute no. It has no role whatsoever. So Remdesivir only in high-risk individuals is something which we should keep at the back of mind, even if actually we know Omicron is unlikely to lead to hospitalization, but it is just that the person is high risk. You do not want to take that risk. So 3 dosages of Remdesivir for them, those who are 65 years plus, and those who have chronic morbidities of significance. Perhaps that is justified.
Also, sir, would you say that at the moment, Delta is not totally gone? So if Delta is there in some, like yesterday, we had a patient with a CT scan with a score of nearly about 12 out of 25 and a CRP of 156, and his oxygen was somewhere in the 92s. So they have given Remdesivir to him. Is it possible that he was a Delta?
True, sir. There is only one thing which I would say. It's very difficult to make a statement with evidence supported by that.
Right. Okay.
To my mind, because that kind of data is not available. So what is important is we may have to rely on our clinical acumen whether this could be Delta.
So it has to be on a patient-to-patient basis, right? I think
also the longer now we will go into Omicron wave, the likelihood that the person might have Delta will diminish drastically. And to my mind, if I was to put a guesstimate, I would not think Delta occurs in more than 5% of cases today. It will become further closer to zero in less than a week's time.
That is very encouraging and very gratifying to hear from you, sir. We'll come to vaccines, which is the last part. Most important question today, 2 which are arising. One person took a vaccine and for 7 months has not taken his second dose, and today decides to take a vaccine. Does it become, which dose is it to be considered?
Ideally, dose 1.
Post 1. Okay, fine. So no more confusion. Number 2 now. He's taken 2 injections and now has got an infection of Omicron. When does he take the next vaccine?
That is 3 months after the Omicron infection.
Omicron. So 3 months after.
Yeah.
So please, everybody, please listen. I in fact got a telephone call from Dr. Gandhi just now. There is a lot of confusion on this. If you have had your 2 doses and have not yet had your, what dose is it being called? Protective dose. Then if you get an Omicron infection, take it 3 months later. Fine.
Yeah.
Number 3, sir. Number 3 most confusion item. Number 3 is a lot of people are developing some sort of fever and body aches after an infection and coming back on the 3rd day getting their test done and they turn out positive. Please clarify, can the vaccine cause an infection?
Vaccine will not cause infection. The process of going to the center where you receive vaccine, how you get exposed at the time of vaccination itself is the sole reason behind acquiring. If it was vaccine related event, it is also possible that you might have had acquired from somebody else with whom you had bumped up. So essentially, vaccine will never result into a true infection.
Sir, why is it being called a protective dose?
I think these are semantics, sir. It is just that.
No science behind it.
No, I think it is, if you call it as booster suddenly would have meant it should be provided to all. No, so you call it as precautionary because you are going to provide it to a smaller proportion of population, or populations were to be prioritized. I don't see more significance in that.
Right. And again, role of prophylactic antibiotics, azithromycin and doxycycline. I think you've answered it very emphatically. Then please, if your question is role of prophylactic antibiotic, then why not role of everything prophylactic?
Nice, sir.
Everything is prophylactic. So I think I have Dr. Gambhir, would you like to add any questions? Because the questions I had received here, I have put them into those categories of clinical presentation, investigation, management, and vaccine. So the questions have all been around them. In case there are any other questions available, we can take them up in the chat box. I have seen that most of them, some of the questions are regarding guidelines, which I don't want to take up here because travel, etc., those are not issues which are solely related to the physicians. So Dr. Gambhir, if there is anything else you would like to ask.
So the questions have been, and we are getting regarding the opening of the schools and on the children. And the children we have categorized 15 to 18, 11 to 15, and then 5 to 11. The queries is coming on the more on the 5 to 11 is because we have made hype, though WHO says that vaccine should not be the first mandate. It is in totality we have to go on the epidemiological and the preventive parts. So what should be the right message now to the parents, and especially the parents between 5 to 11 years?
No, 5 to 11 in terms of attending school or providing vaccine?
Prevention and providing the vaccines, which is available in other countries now, but the booster is yet not. So
I think, Dr. Gambhir, yes, you reminded me very important. There was a question about, first, sir, if a child has high fever today, I think that's, I'm sorry, I forgot. If a child today comes in the age group of unvaccinated and suddenly gets high fever, is our approach any different than what we are doing it just by symptomatic treatment?
No, there is no difference in the approach to manage a child. That's one thing which is very clear. Second issue, what he is asking in terms of vaccination, no, I think it's in a way we are in a better situation that we are able to, we have prioritized the population as 15 to 18 before Omicron struck us badly. Now that Omicron has struck, it is likely to infect almost everybody within the family, if an index case has it. So the decision to extend vaccines to younger age group perhaps will depend on how we move forward with respect to complete coverage of 15 to 18 years age group, and then what proportion of children may be unexposed. So some amount of operations research would perhaps determine how quickly we will have to move towards younger age groups. But those decisions will continue to be fluid, and depending on the evidences, people will have to decide whether we should go ahead.
I am not being able to understand Subir Majumdar's question. He says molnupiravir is 30% beneficial for unvaccinated. Then why not more than 30% in vaccinated?
नहीं सर नहीं इसमें हमको एक चीज समझना पड़ेगा ना, whether it is unvaccinated or vaccinated, the difference of 30% may not change just because of the status, because vaccines tend to reduce the risk of hospitalization. Molnupiravir is also going to add to the vaccine's effect of reducing the hospitalization. In fact, the difference will become so small that significance may not emerge. Now, if you were to compare between vaccinated and unvaccinated, you will find figure continues to remain the same because the numbers needed to detect that very small difference will be so large that even a large study will not be able to pick up. So as of now, if I was to generalize, I would say, don't think about it. Molnupiravir will not have added benefit to those who have been vaccinated in terms of reducing hospitalization, because vaccines by themselves reduce as much hospitalization.
Sir, one question which is coming in, a lot of people are, because a lot of people are getting now visitors from abroad. What are the chances of sort of a mistake happening, that a person comes, travels from England, he gets a negative test, he comes to Delhi, he's got a negative test. Is there a possibility, a lot of people are turning out positive at Delhi airport? They come with a negative report from London, and Delhi airport, they are found positive.
Sir, if the travel is longer, you are
They may have
going to
contact.
provide you are going to provide the add to the time that you require to the window period to diagnose, no?
Okay.
Because if I'm going to, let's say, come from US, no, if my travel was 24 hours, so I'm going to add 1 day for the virus to actually come out as positive. At the same time, we must also remember that there could be technical issues that are associated with testing. Across, I have heard of all kinds of stories where the first test was positive, then another test was negative, then
That is
another
possible.
test came positive.
Sir, there are many people who had 2 shots of Covishield here and then flew down to England or America, took a Pfizer or a Moderna, and now when they come back to India, what is their status for the protective dose?
No, they should not unnecessarily take it.
They should not. But they will not be recognized as, on paper, they will not be recognized as having taken a protective dose.
Sir, whether
Is Government of India recognizing the Pfizer and Moderna?
they should eventually,
Eventually.
because that proportion is very small. But we have to remember one thing. Omicron will infect such a large population base. If you have taken 2 dosages and had Omicron infection, it would almost be treating oneself as having received a booster. So I don't see whether the so-called vaccine passports will actually require 3 dosages to be recognized, as we did for 2 dosages.
2 doses.
So
But
eventually,
sir, is Government of India today recognizing Pfizer?
Pfizer is only technically recognized, no,
Okay.
because DCGI has approved it.
Approved it. Okay.
So
Sir, now internationally, the WHO and whatever vaccine you have taken, so whatever vaccine mandate in America will be recognized in India, and whatever vaccines taken in India will be recognized in
Will be
America.
good.
So
So if you have taken a Moderna or a Pfizer,
yeah,
the expert is giving you a message. If you have taken that, don't come back and unnecessarily take a Covishield again. You take it when the government announces for your 4th dose.
it may not be in our server. It may not be in our servers, but yes, internationally it is recognized as the valid. Now, the Israel has taken and they have gone back of not to go with the vaccine passports and things. So, a lot of experience from the different countries. Now, Dr. Gangakhadkar, last question.
I think we have had a very exhaustive session.
Last question. The WHO yesterday in their press conference of the SAGE meeting, I was also there, have asked the countries to look inwards and see to have a equity. They say if the world equity is not there, then it will be difficult for us. Let us not be. Vaccine is not an individual tool. It is a mass tool. It is a public health tool. So they have agreed and to share all the genomes and whatever technologies they have. Otherwise, it will be difficult and these diseases will keep on coming. So working and looking at the international data, and you are working in a SAGO, the Strategical Advisory Committee on Origin of the Disease, it is a right statement to have a equity of the vaccine? Will it be possible soon? Yeah.
It must be. No, if you actually look back, no, all the variants that came from or were first reported from countries, you find none of these variants came from countries which had high vaccine coverage.
Yes.
They came from countries where vaccine coverage was low. You talk of any variant that has occurred. And the reason is, these if you provide a naive population, you will suddenly find the virus finds too many bodies to replicate, and there is a chance to develop a variant. Whereas what do we do with when we provide vaccine? We try to provide immune response that is equally productive against that particular organism in every person who has got the vaccines per se, whether 2 dosages or 3 dosages, whatever. It depends on the type of disease. So there is a uniform immune response against which the virus has to fight. Whereas when it comes to naive population, when it comes to people who had only had a natural infection, it may continue to vary because they haven't received the artificial uh, sort of stimulator for protection. That's vaccines. So therefore, it is important for all of us to understand that we have to bring in parity in terms of immune response across the world, no, so that the virus mutations tend to remain in our control. Otherwise, we will be subject to the vagaries of the viral decisions, no viruses decision, whether I want to produce a variant or I don't want to
Okay,
produce a variant.
you are right.
So it's important that we provide it to all
No, I
the
think,
people in all the
sir,
countries.
the equity is important because I am only safe when we are all safe.
That's right.
That's the
That's
slogan. Everybody gets it. So I think, first of all, before I hand over back to Ajay Gambhir to give the formal vote of thanks, Dr. Gangakhadkar, thank you so much for sparing your valuable time.
Sure.
It's a pleasure to have a scientist of your stature with us. And I also take this opportunity to thank Deepika from Jagsonpal and Ankit. You've been
Thank you, sir.
wonderful hosts and supportive in the technicality for us. I now hand over the stage back to Dr. Ajay Gambhir to extend the formal vote of thanks.
Thank you, Dr. Grewal. I think we have a lot of questions, most of them been answered, and we have a good gathering today. And what we are doing alternate week is to have a talk with the expert, and Dr. Gangakhadkar and Dr. N.K. Arora are our regular hosts and been talking from the government and scientific perspective. So thank you, Dr. Gangakhadkar. Thank you, our national president and the secretary, and thank you,
In
Jagsonpal.
fact,
Thank you,
Dr. Gambhir, Dr. Jayesh Lele is still there, I think.
अच्छा नो वो कनेक्ट किया होगा लेले साहब की फोटो नहीं दिख रही.
Dr. Lele, are you still there?
And thank you, Amit and Ankit, for holding always on the front stage and the backstage. So next time we'll have the better gathering and we'll involve more of the states to do that, and we'll keep on asking the question and we'll collect the question and be back with you, Dr. Gangakhadkar. Thank you for helping us, always patronizing us. We always, जब भी phone करो, he is always available. Thank you very much, Dr. Gangakhadkar.
Thank you.